Well, folks, welcome to our 9th Bouncebacks Critical Care Book Club, and we are so honored to have you with us. We have a really nice panel here, which I'm going to introduce in just a second. And for folks that have been here before, you know you get 1 hour of free CME, so don't spend it all in the same place. And we're going to have some really good discussion about a maybe not common situation, but a way that we can think about when common situations turn out to be from uncommon problems. So before I actually bring up our main PowerPoint here, I just wanted to introduce our speakers here. We have Chris Colbert, and Chris is the Assistant Residency Director and Assistant Professor of Emergency Medicine at the University of Illinois at Chicago. And Chris, we just got to hang out together in Las Vegas a few months ago at Essentials of Emergency Medicine. So it was good spending time together with that. We have Cody Horn. Cody is an infectious disease physician at Adena Regional Medical Center, where I work. And Cody and I have done programs before, and he has a lot of expertise. So a little bit of a spoiler alert, this does turn out to be something infectious. We have also David Thompson. David was one of the chapter authors with Esther Chen for the critical care chapter 9. And David is an associate professor, Department of Emergency Medicine. He's the director of quality improvement and patient safety at the University of Cincinnati, just down the street from us here in Columbus. And finally, Ben Trotter. And Ben is an emergency physician and the chair of our department at Adena Regional Medical Center. So welcome to you all. And in addition, welcome to folks who have joined us and folks who have joined us from around the world. We have almost 120 people who have registered, and it's an honor to have you here. Countries as far away as New Zealand and Taiwan and other places, over 30 states in the United States, folks have joined us from. So we hope to be true to the hour that we have. And because we hope to be true, I will stop talking and we'll get right to our case. Before we do that, just a very quick accounting things. There are no disclosures. Everyone has a conflict of interest form that we have signed. If you can just sort of point your phone at this QR code, you can put your information in. It takes 30 seconds maybe, and you'll get your 1 hour of free CME. So we'll flash that code again at the very end, which will be nice. So this is a 28-year-old man who is diagnosed with pneumonia, and I'm going to just sort of briefly tell you about his initial visit, and then we're going to very, very quickly transition ourselves to the bounce back visit. So as opposed to the past one where we talked about the initial visit, at this time, we're really just going to talk about the bounce back visit. So this patient presented to the emergency department with shortness of breath and a cough, actually a productive cough. And he had vital signs showing that he was febrile, 100.5. His heart rate was minimally tachy, 102, and his blood pressure was 108 over 59. His O2 sat on room air was 97%. So nothing really too exciting so far, although maybe a little unusual to have what we think is a bacterial pneumonia in a 28-year-old. But we're going to come back to this point later, and I want to just read the chest x-ray finding because this is where things deviate just a little bit from our normal lobar pneumonia. And here's how the chest x-ray is read by the radiologist. Patchy bilateral airspace opacities consistent with acute pneumonia. Given the bilateral nature of the abnormality, this is most likely due to an atypical organism such as Mycoplasma or PJP, pneumocystis. And then the two sentences are where you have seen many times before. Radiologic follow-up to resolution is recommended. Findings communicated to the emergency department. They didn't really say clinical correlation required, but I think they sort of insinuated that. Patient is actually admitted, so we're not saying anything wrong was done, although interestingly was started on medications for community-acquired pneumonia with ceftriaxone and azithromycin. He had blood cultures done. We could talk about that a little bit later. And then he is discharged on oral antibiotics. And the agreement is that he's going to have some additional testing that was done in the hospital followed up as an outpatient. So our story really starts here now when the patient comes back 1 week later. Unfortunately, when he does come back 1 week later, he is a lot worse. And I'm going to give you his history, and then we're going to talk about this just a little bit more. And this, what you're seeing on the screen here is just that initial visit that you saw there. So this is his return visit. This is the actual documentation. Chief complaint, high fever, weakness, 28-year-old male in good general health, doesn't smoke cigarettes, admitted a week ago for pneumonia, and they described the chest x-ray findings and which antibiotics he got. He woke this morning of his ED visit, the second ED visit, with increased cough, right lower chest pain, mild shortness of breath, and generalized myalgias. And they actually went back and looked at his labs from when he was in the hospital and found that he had a CD4 count of 21. The HIV, interestingly, even a week later, was still pending, and they have some negative review systems. You can see the vital signs are concerning. He's febrile, but he's also tachycardic, hypotensive, and hypoxemic on room air. And the physical exam findings you can just read there. The only part I'll just read to you: breath sounds with mild generalized crackles, intercostal retractions, and neck musculature is bulging out during respirations. Not really a good sign. And he's not even a 4-month-old with RSV. So I think you know what I mean by that. All right. So where are we at here? We are at decision point A. And I want to make sure that, let me bring this up here. While I was reading all that to you, I told you I could flash the QR code, but there's the QR code. I guess I didn't have the share going. So there are the QR codes if you want to take a look for your CME. I'll leave that up to just for a second. And we'll put that up again later also. All right. So this was his initial visit. This is the return visit. So what I want to do is bring our panel in here now and start asking some questions. I'm going to throw the first question out to Chris Colbert. And Chris, we have shortness of breath and fever, and we're seeing the patient in the emergency department, tachycardic, hypoxemic, hypotensive. Why don't you sort of walk us through stuff that a lot of us know, but any subtleties that you might have in your evaluation of this patient in your emergency department, Chris? And I can't hear you, Chris. I tell you what,
Okay, how was this?
it's
this?
perfect. It's perfect.
Thumbs up. I'm getting a thumbs up. Copy that.
Thumbs up.
All right.
Yeah.
So
All right.
what I was stating is that I love these bounce back conversations for the simple fact that they're relatable. In some capacity, all of us have been in this and seen from this lens. And you can look back and kind of respectively play the Monday morning quarterback, if you will, and provide a nuance or just a new lens which we're going to see this. So here I am looking at this patient that clearly was seen before, and they're getting worse. The vitals are worse. I'm looking at the antibiotics that were given. So that's my biggest thing that I'm going to run with, is that ideally this patient received medication right under that umbrella of usually organisms are treated with this beta-lactam in some capacity, but it didn't work. This patient bounced back, and it reads that it's a 28-year-old healthy patient. So then my differential says, how healthy is this patient? How consistent is this, and what has changed? Within these 7 days from discharge, and now that I'm seeing this patient, what's different? Between the hypotension on physical exam, is there like a lymphadenopathy that I'm hearing? It's the crackles that are significantly concerning to me as well. Is because crackles give me an insight that this may be a little bit more or something atypical than what is usually seen. And that's where I'm going to start with my decision making in reference to broadening my differential.
So, Chris, you have, and as a emergency physician, we're going to throw Cody Horn on here from infectious diseases in just a second. But we're thinking, I'm guessing you are the same way that I am, in a little bit of a multiple choice-ish type of way. Does this make sort of generalized sense with stuff? But the physician who saw him obviously looked back and saw that not only does he have a low CD4 count, but looked at the chest x-ray finding from previous. Does this change anything about how you initially evaluate this patient at the age of 28?
100%. Having a CD4 count, it gives me insight, it gives me a different direction, coupled with the fact that, again, with the antibiotics, which ideally should have worked, the patient's bouncing back, a CD4 count, I'm definitely going into a different direction with my differential for this patient's presentation.
So walk us through that differential, because obviously it's very different than a general community-acquired pneumonia.
100%, 100%. So CD4 counts, I'm thinking immunocompromised. So once I'm in that immunocompromised category, my differential goes into, is this just not only possibly PJP, is this the CMV, like a pneumonitis. Let's just say hypothetically, this patient, we didn't know, let's just say hypothetically, what had RA and is on some sort of biologic, or lupus and controlled or long-standing steroids. My differential goes into what is atypical. Are we talking fungal? Are we talking some very unique presentation of a TB? Are we speaking of PJP or CMV? Why, with such a low CD4 count, you've got a pretty broad differential for what the offending agent could possibly be.
So final question for you here before we move on to Cody. You're seeing this patient, and it's pretty easy to just throw like Zosyn and Vanc at everybody, right? Are you starting antibiotics up front, or are you going to hold off until you get a little bit more information?
So that's fair. Time
Rubber
is of the
meets the road.
essence. Yeah. So here's the thing, and that's a good point. I'm looking at this X-ray, and know something's different. What I'm going to do at my shop with my resources, I'm going to call ID. I'm going to call infectious disease and state, hey, before I put this patient on a gorillacillin and make them more resistant to something that I'm not really treating, let me get insight from ID. And that's why we have them available to put me in the right direction, because at least sometimes ID will even say, let's pause before we start this gorillacillin on this patient, that this is not going to help and could possibly prolong their stay. So I have a resource of ID at my shop. I would give the patient ID fellow or the attending, usually the fellow, the insight, and then they're going to provide some insight on the next move. And I think that would be best for the patient, as well as can point the right direction in a different treatment and management for this patient.
Well, we're going to come back to that. When do we consult in just a little bit here? But the nice thing is you making that call and waiting for 20 or 40 or some minutes for them to call back. We don't have to wait tonight because we actually have infectious disease on the call here. So Cody Horn, thanks so much for joining.
Yeah, thanks for having me.
Okay, so I want to ask you, if you get that call from Chris, he reads you that chest x-ray finding, tells you about the CD4 count. For this specific patient, how are you now making your recommendation? Do you want to start antibiotics right away or anything else that you would do instead? And what recommendations are you going to give Chris over the phone?
I think we have to really cast a wide net on this one because the guy could have common things. Common things are common regardless of what you have. I mean, this guy could still have a community-acquired pneumonia, of course, but with the CD count so low, CD4 count so low, and being acutely ill, it could be anything. It could be non-tuberculous mycobacteria. It could be TB. It could be fungal. It could be viral. It could be anything. And then taking into the clinical context, he has a high-grade fever. You have to look at everything too. So different appearances on X-rays can help. But with this one, you've got these bilateral opacities. Could be diffuse alveolar hemorrhage. It could be just cardiac edema or pulmonary edema from cardiac issues, although he's pretty young. Pneumonitis, lymphoma. He has HIV. He has AIDS. This could be a lymphoma case. Tuberculosis, of course. You just got to cast a wide net and I wouldn't start everything at once. You have to kind of whittle down a little bit.
So Cody, just because I'm this guy, I'm going to give you the same sort of rubber meets the road Fisher cut bait scenario that I gave to Chris before. And I'm going to ask you, you get this call, there's all these possibilities. Maybe even you happen to be walking by the ED and you can actually see the patient and see the film yourself. What are you going to recommend at this point? Any medications, any further testing that we as EPs should do at the bedside in the ED?
I think for further testing, I would like additional imaging for one thing. He's sick. This guy needs antibiotics. I think that antifungals is probably not the time, nor would it be time to treat like a tuberculosis or non-mycobacterial. I would need more data for that. Again, common things are common. I don't think Zosyn's a bad option here. Zosyn or cefepime, I'd probably hold in the Vanco personally. But looking at this person, atypicals, fungal, those are going to be higher on the list. Things like, pneumocystis, those kind of things with these patients need to really be in the top tier of your differential here.
Okay, so I'm going to bring Ben in here. And Ben, you're the chair of the ED at my shop. And I want to ask you, honestly, for CAP, our initial antibiotic is typically a third-generation cephalosporin, such as ceftriaxone, which was started last time the patient was there, as well as a macrolide, possibly azithromycin. But when do you get concerned? And I'm just saying in general, and then we can make it specific to this patient too. You can do that if you'd like. But when do you get concerned that those antibiotics won't work, or maybe that it's not an infectious process at all?
It's a great question. It's tough. Everybody's touched on all the aspects that we're taught historically: immunosuppression, risk factors, commingling with other inhabitants, all those other pieces that we go through just reflexively in our mind as these patients present. But for this one, in this particular case, I think anytime we have a patient that comes back that's already received antibiotics, that's been treated appropriately, theoretically completed that antibiotic course, but failed and has progressed, we have to open up our mind to other aspects. And so this day and age, we have great resource to that. We have EMRs that interlink and communicate. We are better now than we ever were at teasing out these atypicals, because we know what they're treated with before, what they've had. And so as we dial in on their history, have they been to the hospital multiple times? Are they treated for pneumonia every other month? Do they have those other historic risk factors and we're not treating them correctly? That's how we direct our next steps. And that's how I look at it in the department. And then we're fortunate enough to have a pharmacist in the department, in our department, that continues to help us with antibiotic stewardship. And so we limit the use of our typical medications on our typical presentations when they're not needed, and then help expand our focus on those other atypical presentations and utilize the right medications when appropriate. And that's just how our era of medicine is going. We're all going in that direction. We have to get comfortable with it. The way that we used to look at it is still always there. It helps drive us. It gives us that feeling inside that we should pay attention to. But now we're starting to use more data, and we have to be open to it and acknowledge it.
So Ben, follow-up question. Do you agree with Chris? You would have called a consultant first, or would you have started the patient on antibiotics and done anything differently before you reached out to a consultant?
I probably wouldn't wake Cody up in the middle of the night at our facility.
Okay.
Our team doesn't have the residents and fellows for all the different specialties. But for me, I think we treat it like it's typical. This patient's sick, there's no doubt. He had standard treatment that we would assumed would have been appropriate for a community-acquired pneumonia when he presented, and was treated with that in the hospital stay, and then has progressively become worse. So I would escalate care, start those antibiotics, and then work to the path of admission, or if I don't have the resources at our facility, get to him in a facility that's going to do those next step testing that he clearly needs.
So David Thompson, I want to bring you in. You are one of the chapter authors with Esther Chen. And first of all, I want some of your thoughts on what's come out so far. And the differential that Cody Horn from infectious disease gave was, super broad, and it's really important. I mean, there were a lot of things on there that I wouldn't not really have considered. I mean, both infectious and non-infectious type of etiologies. So why don't you sort of bring all of this information together, give us some context as far as your thoughts on this patient. Then we're going to bring Cody back in to answer a question from the chat, and I'll flash that QR code back up there in just a few minutes also.
Sure, thank you. So in this case, I think we're talking about workup of something unexpected, which in this case was a multifocal pulmonary infiltrate. And it's worth saying that this chapter was written well before COVID came upon us. But when we find something that we're not expecting, a multifocal pneumonia in a young person, that's kind of a bit of a curveball. And so I would ask myself at this point, what might have seemed like a simple case really isn't so simple. So at that point, I would return to the patient's bedside and obtain additional history and physical exam. Under history, I would obtain data such as travel history, additional symptoms like weight loss, rashes, social history, housing, things like drug use, sexual history, asking about bites, environmental exposure, herbs, supplements. And then under physical exam, examine some things that I might not typically examine, like do a more detailed heart and lung exam, listen for murmurs, do a lymph node exam, which I don't always do, looking for rashes, do a more detailed oral exam, maybe even do a genital exam if in the right context. And then I would use this additional history and physical to further refine my differential diagnosis and consider further testing and therapies.
So Dave, Dave and I don't think we have actually met in person, but I will say that I already like you because getting back to the bedside, there's so much stuff that we can find. And, I totally get it that a lot of times the physical exam doesn't really help us that much. But when it does help us, because we find Fournier's gangrene, or we find a loud heart murmur that the patient didn't have, or multitude of other things, and we're going to talk about some of those other things in just a sec here, sometimes that can totally change the trajectory of our evaluation. So, Dave, I'm going to bring you back in here a second. And I told folks I'd flash that QR code back up here. So let me just do that while we're still talking here. But what I want to do, Cody, is bring you back. And then, Dave, I'm going to ask you to sort of weigh in on some of this stuff also. First of all, there's a question that was asked about some additional surrogate labs that can be done to look for PJP. But the other thing I was going to ask you is, as far as starting medication, and trimethoprim sulfamethoxazole would be really the first line medication for that, right? Is there a rush to get that started? Or these days, as opposed to the early days of HIV and AIDS back in the late 90s, early 2000s, these days, would we want to really have better confirmation of that, for example, with bronchoscopy?
So I'll answer the chat question first. That's a great question, actually. And so they ask about beta-D-glucan, or Fungitel as the name of the test, which is a component of beta-D-glucan, is a component of fungal cell wall. And so pneumocystis is a fungus. And so that can be elevated in times of fungal infection. That can also have a false elevation in people who are receiving dialysis, also recent beta-lactam use. So while it could be helpful for a rule out, it may not be helpful for rule in. It might be falsely elevated, and I encountered that quite a bit. So that's kind of needed to be interpreted with a grain of salt. But yeah, that's an excellent. I would order that right up front too. At our facility, that takes like a week to come back, so it's kind of tough. LDH is a little bit better. It's useful in this HIV population. It's not so useful in people who have like hematologic malignancies. It's going to be elevated anyway. So again, it's kind of not going to help you out. But if it's low, that essentially will kind of lower my index of suspicion for PCP pneumonia if either one of those tests are low. And I'm kind of not sold on the diagnosis anyway. That would probably rule that out for me, honestly. But great question. And then Michael, your question was
I'll ask you my question again in a second,
there
because
we go.
there were so many questions at the same time. I totally get where you're coming from. And I want to actually thank Patrick Sylvester, emergency physician from The Ohio State University, who was one of our panelists last month. So Patrick, thank you so much for that. As far as some tests that can be done, I know, for example, for cryptococcal meningitis, the serum cryptococcal antigen is 95% specific, or sensitive actually, for finding that. And, thinking something like LDH, it sounds like it doesn't quite have enough specificity to rule it in, but maybe it is a little more of a sensitive test as far as potentially ruling it out. How about as far as, and I'll just follow up that question that Patrick asked, combining, because our CD4 count is, combination, right, of the percent lymphocytes times the percent CD4 cells, right, times the white blood cell count. But what if we don't have those percent CD4 cells, just have the white blood cell count and the percent lymphocytes? Can we use that as some type of surrogate for the CD4 count?
Yeah, you can multiply those together, and that essentially correlates with their CD4 count. So an absolute lymphocyte count of about 2,000 correlates with roughly a CD4 count of 200. Back when I did residency at UF, I had a professor that would swear that he could tell the CD4 count based on someone's hair. If it was curly, he would say their CD4 count is lower than 200, and if it was straight, it would be above 200. And he swore by it, and he was pretty accurate with it, surprisingly.
So I'm going to actually now go to, as far as other things that are even more accurate than just the curliness of someone's hair, because there are actually some physical exam findings, and actually a CD4 count of 24 is an AIDS defining finding, right? But as far as some physical exam findings and some historical findings that would increase our suspicion, like David was thinking pre-test probability, right? Does this patient have a risk of it? And so this is a lot of information on the page here, but some things that we can look for on physical exam can be actually pretty helpful for us as far as making a diagnosis of HIV or AIDS. Cody, this is back. Still to you.
Okay. Yeah, so these recurrent mucocutaneous lesions, thrush, recurrent shingles, recurrent zoster. You'll also see some people with these plaque materials on them that ends up being like sarcoma, which can happen in the mouth, can happen in the skin, it can happen intravascularly, interstitially. So any of these kind of things could help cue in this person has AIDS rather than a higher CD4 count where we're less suspicious. Blurry vision, of course, with CMV, retinitis, those kind of things. And so usually it's going to be the thrush, honestly, or this diffuse widespread rash, kind of lymphadenopathy for this acute HIV infection too. So that'll cue in some of those findings.
So one thing I just wanted to highlight of all of these words is that oral hairy leukoplakia, those bright white vertically oriented lines on the tongue, on the sides of the tongue or the buccal mucosa, simply having a patient stick their tongue out and move it side to side, if you have that, especially in a patient where there's a suspicion, that would certainly increase our risk of that patient having AIDS even before a test comes back. And I know we already have the test back with this patient, but is that something you find commonly in patients with AIDS, Cody?
I haven't seen that one for a while, honestly.
Okay.
Yeah, it's been a minute since I've seen that one.
Okay. All right. Fair enough. Fair enough. So let's move on to a branch point to sort of end up this segment here. They're going to find out what the actual provider did. We're going to get to our next set of questions. And so what I wanted to do is sort of go around the room here because, man, when I first started practicing medicine, I was like, chest x-ray is so good. Or even like, I mean, this is sort of funny, but we take our dog to the vet and they're like, well, let's do a chest x-ray. I'm thinking to myself now, I was like, man, how helpful is a chest x-ray, right? And so it's really amazing that sometimes when people have symptoms of pneumonia, you can have a totally normal chest x-ray and then you get a CT scan and have some sort of multi-lobar type findings. And of course, we can throw ultrasound as far as the discussion further also. So David, why don't I go back to you and we'll sort of go around the room here a little bit. But when do you sort of bite the bullet and decide to order, for example, a non-contrast chest CT, looking for an infectious etiology, or either trying to, or maybe even just trying to further define what you're seeing on your chest X-ray?
Increasingly often over the course of my career, I have done that. I used to not do it at all, but now if I have fever without a source and my suspicion is high for that, like there's some tachypnea or a symptom, I may do that. And increasingly, just radiologic imaging has proliferated in general. So we're doing a lot more CT scanning of the chest and finding other things. So
I don't know about you, I always feel a little guilty when I'm doing it. I feel like I'm giving the patient too much radiation, but sometimes there's a profound change in the management.
if it's
You
chest
get,
CT or lumbar
yeah,
puncture, I often will go with chest CT first.
yeah, yeah. So the totally normal chest CT to me feels like this patient does not have, obviously a lobar type pneumonia with that. And Cody, I was just going to ask you real quick. One thing that I sort of remember is that even in patients with AIDS, still the most common pneumonia is a pneumococcal pneumonia. Is that right? Not PJP.
Yeah, it's correct. Common things are common, even with this population.
Okay. All right. So going around further, why don't we ask Ben and then we'll ask Chris that same question as far as when we decide to look with the chest CT when you have a normal or normal-ish type of chest X-ray. Ben, when do you make that decision?
I'm a simple person at baseline, so I look at myself kind of like a detective in this instance. If we don't have a story, physical exam findings, or labs or imaging that adds up to what the patient is showing us, then I move forward with further testing. And that may not be accepted a lot of times, for throughput and all those other pieces. But I think in my mind, even though I do worry about that as the director, I think we owe it to the patient to make sure that we're managing these pieces correctly, or at least admitting or discharging or providing them with the care that's most appropriate. And the benefit to them far outweighs the time it takes us or the resource drive that it ties up in these instances, especially in this type of case here where you have presentation that's progressing or a patient that has an undiagnosed or undifferentiated illness that you are just throwing antibiotics at. So that's my thought.
Chris Colbert, any specific patients come to mind when you think of a patient who had either a normal or equivocal chest X-ray and the chest CT just totally made the diagnosis for you?
100%. And I think that because I too am working on a book. It's called The Things I've Missed. And I'm on the cover of the book like this. Number one, if the vitals are abnormal, and I'm looking at an X-ray, I'm telling myself there's something I'm missing. If this patient is hypoxic and has a fever, there's something I'm missing. If it's not an endocarditis, I've got to, now mind you, we're just talking here about a differential. I'm thinking, what's the next step? Coupled with that, it's the abnormal X-rays, at least that subtle abnormal. You know, it's that we're always taught, oh, a bat wing deformity, and you're looking at the X-ray like, is this a baby bat, a large bat? Was the wing broken? So when you have these X-rays that give you concern, and it's a subtle concern, and the patient bounces back, that's when I will escalate the imaging to better understand, or to gain a better understanding of what this X-ray is. Is this an obstructive pneumonia that's something else? Is this something weird that just presents and it's not a true bat wing, like a true bat? Like I'm looking at this saying, this doesn't even look like a bat. Or why is this diffuse? What gave me more insight to what this X-ray is? And those are the two big things. If I'm looking at this X-ray and I'm thinking, this doesn't look right, and the patient doesn't present with what I'm seeing on this X-ray, that's my biggest one, and the abnormal vitals.
Perfect. So Cody, I asked you this question before, and I think it was one of the ones where I asked so many questions at the same time and sort of fell through the cracks, but super important question. Ben Trotter calls you, and he does call you at 3 a.m. because he's not as kind as he's presenting himself on the phone, on the call here. And he says, look, I've got this patient. Do you want me to start them on Bactrim? It's 3 o'clock in the morning, and it's a Wednesday. What do you tell him? Yes or no? Rubber meets the road.
I think at the end of the day, yeah, because if they're a healthy patient, they have healthy kidneys. The worst case, they just get a couple of doses of Bactrim and we can pull it off. I can come in the morning. But these patients can decompensate really quickly, very quickly. And so it's important to start antibiotics. If the side effects are low, if they can tolerate it, if they tolerate it before, if they don't have a soft allergy, if they're not, a 90-year-old with CKD4, yeah, I would, at the end of the day, I'd say absolutely, let's do it.
Okay, that's not going to interfere with our ability later to make a diagnosis. Just for example, if you did a bronchoscopy, for example, on this patient.
No, it wouldn't, because one of the methods to diagnose is to do a PCR. A stain would still be there. You don't need a live organism to stain. So you just need an organism, live or dead, or a PCR or genetic test. So a couple doses isn't going to hurt anything. It might save the person's life.
Got it. And final point with this is that if you're working in an outpatient setting, just one Bactrim DS twice a day, not good enough.
Yeah, it's if they've got acute disease, yeah, because they're split between severe, mild, and moderate, or mild and moderate. But I haven't seen a mild case of this for, I don't know if I ever have, honestly. I think these patients decompensate pretty quickly, so I don't think it would cut it too much.
So I want to just bring in a couple of things from the chat. There was sort of some funny ones here with the absolute lymphocyte count is the poor man's CD4. And then a couple other comments here about not using Zithromax, especially azithromycin, I should say, monotherapy, not to use that. David Thompson agreed with that. And I'm sure you can all see the chat yourself. Okay, so what happened with our patient here? So the patient actually, they looked and they made the note of the CD4 count of 21, like the diagnosis of AIDS, and they thought that PJP was the most likely. This is what the clinician thought. They started the patient on trimethoprim sulfamethoxazole IV, as well as, and we haven't really talked about this yet, as well as steroid medication with Solumedrol. The patient remained tachycardic. They said he was mentating well, but he had an increasing amount of requirement for oxygen. They repeated the chest x-ray, ill-defined opacities within the upper lobes, right greater than left, and they say they haven't significantly changed those since the prior exam, and blunting with the claustrophrenic angles. And so they went back and they said they put the patient on 6 liters of oxygen, but still only static at 91%. However, at this point, the respiratory rate has increased and is now 36. Mentating well, he's diaphoretic and asking for water. This is not a really great situation we're at. So, Chris Colbert, I'm going to ask you, our patient appears heading for respiratory failure. What do you think? Where are you going from here with this patient's management of their oxygenation, their ventilation, and their airway? I think you're still muted, Chris.
I'm going to get this down. I'm going to get this down and
I was
impress
trying to
everybody
avoid
here in a
having to
second.
say that the whole time, but
I'm going to impress everybody here in a second. But so, short story shorter, I tried to intubate last. I tried non-invasive. I would try the BiPAP. There are certain patients that, and as I practice more, I'm less to just go right for the intubation. I'm utilizing the BiPAP. I'm utilizing the high flow, and trying that out, because also the more you intubate these patients, the longer they're going to stay in the hospital as well. So if I can do the best I possibly can to see if we can tailor this BiPAP, initially go from whether the high flow and then BiPAP, and that has a better outcome, that's what I try first. And again, I don't put everyone in a box. I'm looking at vitals. I'm looking at a whole lot of others. I'm looking at the stability of the patient, because we can always intubate. We can always intubate this patient. That's not a problem. The question is, do you want to look down the line and think, what can we do here to have a better patient outcome, less time admitted to the hospital, and see if this BiPAP works? So I would try the BiPAP first.
All right, David Thompson, similar question to you. Any airway or ventilation tricks and tips that you have for this patient?
So the question of non-invasive versus intubation, the historical dogma answer to that question would have been yes. The patient should be intubated because pneumonia, particularly a multifocal pneumonia, does not resolve rapidly, and historically non-invasive ventilation was thought to be for short-term use only. However, in this day and age, no, I also would not intubate the patient. I would titrate up respiratory support with the goals of improving his current state while we gather more data. Even if the patient required intubation later, we would want to optimize him to improve the conditions in advance.
So I'm just sort of wondering, Cody, you would agree with the Solu-Medrol that was started on this patient?
Yeah, I would definitely start steroids on this patient. Typically, we use steroids. Prednisone. I'm not sure about the data specifically to Solu-Medrol. I don't know if it was included in that study or if it was just prednisone, but steroids in general should be started. Yes.
So I want to relate that back to what David just said, because yeah, in the past it was like, I mean, I'm not sure, David, how exactly old you are, but probably you were sort of with me before the days of the non-invasive, and if you came in with bad, flash pulmonary edema, pretty much you got intubated, and you didn't have even that time to wait while we tried to either diurese you or decrease preload with nitrates, et cetera, et cetera. But in this situation, the reason I'm sort of saying this is because if you start the patient on steroids, Cody, I'm curious how long it's really going to take before that might actually have an improvement. Because even if we could have this patient wait a little bit longer, the multilobar pneumonia maybe progresses, but maybe the steroid medication helps a little bit more quickly with that. And I'm interested, David, to have your follow-up thoughts on what Cody's going to say.
Yeah, the steroids, typically you see a pretty good improvement in the first 72 hours generally with this. If you're not seeing an improvement with steroids and the right antibiotic, you might need to change medications, and it might just be, you're behind the ball on the airway at that point. But typically they turn around if they're going to within 72, 96 hours, honestly.
So I when you said 72 hours, I thought you were going to say like 72 minutes, but 3 days
No,
is
no,
like
not that
an
quick.
eternity. That's like infinity for us in the ER. So that wouldn't really necessarily help us. So we shouldn't really expect to see, for example, like with an asthma patient, and like maybe between 1 and 6 hours or something, have at least a little bit of improvement at that time.
Yeah, it's much longer than that.
Okay, gotcha. David, further thoughts on all that?
Well, I think COVID really changed the game on non-invasive respiratory support. However, this question was already sort of, the tide was turning even before COVID, that it's appropriate to trial non-invasive support for cases like this. And I still think we come back to the basics with when to intubate, and that has to do with failure of oxygenation, failure of ventilation, mental status, work of breathing. Keep it simple. It's ultimately a clinical decision.
Ben, why don't you give us your thoughts on this situation? Then we have a question from the chat I'm going to throw out to the group.
I agree with everything that's been said. I mean, I think that our era in the management of respiratory failure has drastically changed even in the short time I've been doing this. We are much more aggressive with non-invasive, we place it earlier, we put it on longer, we use it in, I guess, more concerning presentations than we ever did before. And even nowadays, you'll see people using it, and especially in the COVID era, with altered mentation, concern for vomiting, all those other pieces are still being pushed on the boundaries of that. So I think the use of it, and as early and aggressively as possible, is the way I would look at it.
So I'll throw this next question out to the group. This is from JJ. Any evidence for proning in severe PJP? Or would anyone try that? It's a deafening silence. I have not, I mean, honestly, the number of patients so for my own personal, as in addition to doing full-time ED, EM, I should say, also worked at the AIDS clinic at Ohio State for 11 years, starting in 95 and ending in 2006. So for those times, we saw a lot of patients with all these opportunistic infections because that was before the protease inhibitor medications were even introduced. And so, I've seen a lot of patients with pneumocystis. However, as far as seeing patients, especially recently, come into the ED with pneumocystis has been pretty unusual. So I couldn't really answer that question as far as based on my own experience. I'd be curious for anybody else here if you have seen a patient with PJP or if you've even heard of anybody trying to prone that patient at all. Although I think some of the recent literature, even with COVID, is not quite as encouraging as it seemed initially.
I mean, I'm not pulmonology or critical care, but I don't think I've ever personally seen a PJP person proned. But I'm not sure of what the literature data says on that. I just haven't seen it.
Okay. All right. Fair enough. Well, I thought it was an interesting question. And I mean, certainly we want to do everything we can to avoid intubation. And I mean, it's a pretty benign type of intervention, although it could be a bit labor intensive, certainly, without a doubt. Okay. So there was one other question that I wanted to bring in from the chat here. Patrick Sylvester says, devil's advocate on delaying intubation. If a deep specimen, for example, bronch, is felt to be the key to the case, I wonder if that might tip the balance towards intubation a little bit earlier when we just need to clarify the diagnosis. Just say, for example, the patient presented at 3 p.m. instead of 3 a.m. Cody, I'll throw that one out to you. Is there any thought if you would do a bronch on this patient, can you do that without the patient being intubated with this amount of respiratory distress?
I always throw out maybe consider bronchoscopy, and then the experts take it from there on the lung side or anesthesia. But a sputum can sometimes be just as good as a BAL, honestly, and I think a sputum should be going first rather than going forward with the bronchoscopy. It has more risk, and sometimes you can get that yield with the spit or with sputum. It depends. Non-HIV patients, the amount of fungi there is not enough, and the sensitivity is very low. We're talking like 30s, 40s for that, rather than compared to a higher burden of infectious material with HIV folk. So with this person, it's very reasonable to do a sputum before you go to a bronch.
So I'm going to bring in one other scenario to you in just half a second here. But before we do that, and it sort of speaks a little bit to that answer you just gave, but this is from Lena Carlton. Is the slower rate of clinical improvement with steroids due to the nature of the disease or for different steroid dosing, for example, in patients with PJP as opposed to asthma or some other COPD reason we'd give steroids? I made the second part of that question up there, Lena. I think that maybe was what you were saying. And if it wasn't, please clarify that in the chat. And then Dave, if you want to also clarify cultures, are you thinking blood cultures or are you thinking more cultures for PJP? So Cody, how about that question that Lena asked?
I think it's a good question. Absolutely. I don't exactly know the answer to that clinically. I think that more so that it's, COPD and asthma exacerbations are more of like a physiological underlying condition with the lungs itself. This is more of an infectious issue where you have a high burden or low burden potentially of infectious agents, and your body's trying to combat that, and it's also raising a lot of inflammation when we're treating it. So when we start these antibiotics, you have a high basically death rate of these organisms, which cause more instability in the lungs, more inflammation, and I think that culminates over time, probably. And so that's why you're not going to see this rapid improvement with the steroids because you're kind of fighting this infection as well as it's not really a lung disorder per se, like asthma or COPD, if that makes sense.
So Cody, when we sent out the format for us to talk about it and get the discussion points that we're going to have, one point that you wanted to make was the fact that even though this patient with a crystal ball, or maybe even just correlating the chest x-ray findings in their history, we're thinking, well, maybe they have PJP, but just because they have PJP doesn't necessarily mean that that's from AIDS.
Yeah, that's correct, and this is easy for clinicians to get tunnel visioned on this. Is that PJP is only occurs in HIV/AIDS patients, and it doesn't. And it's not necessarily even correlative to, well, it is correlative, but it's not to the exact 200 CD4 count. Patients with CD4 counts of 230, 240 can even get it. It's just way less likely above that range. But anything is possible in medicine, as we know. But people who are on chronic steroids or severely immunosuppressed from other medical conditions, who have stem cell transplants, even sometimes solid organ transplants, can be more likely to get PJP pneumonia. So it's easy to get tunnel vision and just thinking, oh, this person has, they're not HIV/AIDS, they don't have PJP pneumonia. Whenever this lady has, she has dermatomyositis, polymyositis, and she's been on 60 milligrams of steroids for the past 6 weeks. Those people, I've seen plenty of rheumatological disorders get it just as I have HIV/AIDS.
Wow, it's a really good thing to think about, because certainly we don't want to, again, like you said, have tunnel vision with the fact that that's what the underlying problem is, when it certainly could be from something else. So some of those questions, even that some of the other folks mentioned before, as far as thinking if there is some type of immunosuppression or medications that make them immunosuppressed, certainly important to think about. So Dave Thompson, will you answer? There was a question from Dave about blood cultures, and you had an answer to them. And then I'd just be curious if anyone had further thoughts on our discussion points. Then we'll move on to what happened to the patient and our final decision point, C. The question from Dave was, I'm wondering how often that blood cultures change management. And Dave Thompson, you put an answer in there. Do you want to expand on that a little bit? Might be easier verbally than just by typing.
My work is clinical and administrative. So for 7 years, I worked on sepsis for my department and reviewed all the sepsis cases and was very tied in with that disease process. And so blood culture data is one of the primary ways that antibiotics get narrowed during a patient's hospital course.
What percentage of the time of patients who have pneumonia do the blood cultures come back positive, roughly?
I would have to give that one to Cody if he knows. I don't know the answer.
I don't even know. I think it's probably a low percent, honestly. I just guesstimate 5% or less, just from personal experience.
The number that I sort of remember is 3%, but it might not necessarily be that. And I know that when all of these markers of quality started coming out as far as getting blood cultures, there was a lot of resistance on that because it was so infrequent. And then the other problem was that as far as the requirements to do that, it wasn't just with all pneumonia patients. It was more if they got admitted to the ICU. So I'm not really going to sort of go into necessarily that, because I'm not an expert on what those actual specific quality markers are or how you need to fulfill them. But I will say it's not just blood culture you need to get on every single patient who has pneumonia. I mean, of course, a lot of those folks go home. So let me move on just a little bit here. This is what happened with our patient. What did the actual provider do? They increased the oxygen to a non-rebreather, initially stabilized at 92%, but went down in the 80s, and they did just what we had all talked about, is put the patient on BiPAP. So we have some labs here. We don't have a diff with this patient, but the patient certainly does have at least a little bit of leukopenia. I know it's only 4.5 and maybe normal is up to 4.6. But in addition to that, there are some LFTs that were done. We don't have an LDH. I know we had talked about that earlier. So that could have been one interesting thing to have on there. So let's move on to our final decision point, again, putting all of us in the footsteps of the emergency physician. And I wanted to just sort of start this off by talking a little bit more about BiPAP. And we're all obviously big fans of BiPAP. Ben, I'm guessing you are probably the youngest of the group. And so you didn't remember that time when we did not have BiPAP. And I'm sure there are other jokes I can make about you being younger than the group, but where do you start? Do you talk to the respiratory therapist? They put a patient on BiPAP, or do you actually ask for specific specific parameters for the BiPAP you're starting?
I think that'll be department dependent. At our department, we actually have in-department respiratory therapy, so they usually do a pretty good job of starting off with aggressive settings and then titrating back when appropriate, and that's per the protocol that we've established over time within our organization. But I think it's prudent for any of us to have an insight as to what those actual settings are, particularly if you are going to work where most of the emergency medicine is done in our country, and that's in critical access facilities. So we got to make sure that you can put out that information and give it to the right people. So I guess historically, or what I've always started with, is 15 and 5, and then we start at 100% FiO2, and we'll titrate backwards as the patient tolerates or as we get information to correlate. That's me. Others may do differently. I think some of it is too dependent upon patient body habitus, all those other pieces. But
Chris Colbert, let me ask you this similar question, but when you have a patient on BiPAP, this is a little bit of a higher risk scenario. For example, maybe they could vomit into their mask, or if you do need to intubate that patient, you don't have a whole lot more room to move if they get hypoxemic on the BiPAP. It's not like you think you're going to make a significant improvement by, for example, bagging the patient's oxygen level up before you do the intubation. Any specific BiPAP pearls that you want to share with us? Or you said you're writing the book on your own mistakes or something, something that you've learned with the years of experience you have that you could share with us so other folks don't make those similar errors.
So the big thing that I do now, and what I communicate with my residents, is when you prepare your BiPAP, make sure everything you need for intubation is available as well, and that you can see the patient. Those two big things are huge. You can't just put someone on BiPAP and walk away. You can't just put someone on BiPAP and not see them. And also, you can't put someone on BiPAP and just think, this is going to work. I don't need to prepare anything else. This needs to be a conversation with not only yourself and your nursing staff, but also with the resident as well. This is where we're going. And again, I echo the sentiment of we start with high BiPAP. I'm 15 and 5, 100, and we can always titrate down. If you're going to do this, you commit. You commit to a good patient outcome. And the best way to do that is to give everything you can up front, and then you dial everything back. And with dialing back comes, I'm looking at the patient. I continue to monitor the patient. And with that, you ensure the success of the BiPAP.
It's amazing to me in the ED that like an hour goes by like a snap of your fingers. It's just incredible how fast time can pass sometimes when you're busy. But we always need to balance those 3 S's, right? Patient safety, and of course that's first, but the balance of patient safety, patient satisfaction, as well as our speed, right? Throughput, as Ben talked about before. My thought, though, is that if you have that patient on BiPAP, in some ways, I'm even a little bit more concerned about that patient than a patient that I've intubated because, the intubated patient, I mean, they certainly could get worse. They could develop a tension pneumothorax. All kinds of other problems could certainly occur. But that patient with BiPAP, we really need to sort of remind ourselves, and I need to do this myself also, that I need to really get back there and check that patient. Like every time I walk by that room, I want to be walking in and taking a look and making sure that they're still doing okay, that they're improving, or if they are worsening, that I can get to them quickly as far as intubation or some other type of measure that I need to do. Dave Thompson, David, what are your thoughts on BiPAP? I know we've talked about it a little bit, but other sort of pearls born of wisdom that you could share with the group.
Use of BiPAP has really proliferated over the duration of my career. The areas I see it used mostly are growth in it, particularly throughout the pre-hospital setting. EMS is doing many fewer intubations than in the past, and it's probably for the better because most agencies didn't have RSI drugs to use, but also its potential to avoid intubation and turn around cases of heart failure, COPD, and asthma. I think certainly patients are benefiting this. We're probably doing less intubation in these cases. However, medical complexity has grown exponentially, and so we're making up for it in other areas.
So I'm going to do this. This is what the patient had. They actually paged infectious disease. So good job. We all thought that was what should be done at some point. Diagnosed pneumonia, fever, AIDS, and hypoxemia. and the patient did get, obviously, of course, admitted to the hospital. And I believe this patient, and I need to sort of confirm this, I believe the patient improved and then actually went home also, as would be expected, because hopefully that was the correct diagnosis of PJP, which was confirmed later. So with our last remaining 4 minutes, I'm going to ask each of us to give a 30-second sort of summary take-home points. I'll put that QR code back up again, and then remind folks that they can sign up for the next book club. The easiest way is just go to EM, like emergency medicine, so embouncebacks.com. You can sign up for the first Monday in December, a 50-year-old man with a pneumothorax. But before we actually even get there, why don't we do this? We'll start, we'll go in alphabetical order. Why don't we go with Chris, Cody, David, and then Ben, and you can each give us your 30 or 45-second take-home pearls. We'll end exactly at 9 o'clock. So Chris Colbert, thanks again for joining, and what should the listeners and all of us take away from this tonight?
So one of the biggest things to take home is that this is great conversation. Having these bounce back conversations and meeting once a month and within the community of emergency medicine with these relatable narratives, it helps everybody. It helps the management of the patients. It helps us. It assists in our confidence in what we do, to know we're not the only person on the shift thinking at 2 o'clock in the morning, am I doing the right thing? So that helps a lot. Cody, I'm honestly glad you're here, because there's a lot of questions I had, and if ID says I'm good, then officially I'm good. That's it. Again, I think the big thing is to have a really broad differential. Don't anchor. It's just a matter of time when anchoring is just going to get you stuck, which is what I say to the residents. And if you're going to put someone on BiPAP, you have to remember, if you're putting someone on BiPAP, you've got to keep an eye on them. You've got to prepare, and you have to continue to monitor that individual once they're on BiPAP.
Fantastic. Cody Horn, give us 30 or 45 seconds of pearls.
Absolutely, I agree. Don't anchor. I mean, these people can have anything under the sun, so don't hesitate to call your ID colleagues. We love a good case. We love a good conversation. We love teaching. So it doesn't matter if you're a resident, if you're attending, if you've been practicing for 50 years, I love teaching. These people are sick. Anytime HIV/AIDS walks into your ED, just listen with open ears, get a good exam, get a cast a wide net. If the medications have low side effects, use them, call us.
You know, in some ways, it's not really what you know, but realizing when there's something that you don't know and you need some help. And in the context of that, Ben Trotter said he wouldn't necessarily call you at 3 a.m. and you just ask folks to call you. Should we call you at 3 a.m., Cody? It's on tape here.
You can't, I may not answer, but you can certainly try.
All right, fair enough. All right, David Thompson.
I'll just echo the comments I said earlier. And when aspects of a case aren't adding up, you find something unusual, like a strange fracture pattern, an unusual chest x-ray, take a step back to reevaluate the big picture on your case and reconsider how you're framing it. Consider return to the bedside, get additional history, do additional physical exam, consider expanding your differential.
Awesome. Thank you so much. And Ben Trotter, if you could share some pearls of wisdom with us also.
I think if you look at this case, it was actually probably handled pretty well. First visit to the admission, to the care, and then the patient returned. And the point of that is when that patient returned, we're not taking a back seat anymore. We're not moving slowly and methodically thinking our way through this. Manage the patient aggressively, add on the antibiotics for what we consider to be typical, is the picture, and then compile our information, use our resources to go that next step. Just as Cody said, it's the next step. It's finding our way through all the information that was collected before, and that can be challenging depending where you're at. But this patient was not better, progressively got worse, and had an appropriate treatment already. We owe it to them to do those next step things. Look at all the labs, find the other information, more bedside evaluation. In this case is a good case. It was managed well, but there's so much to learn from it about how we approach our emergency medicine and bedside, treatment.
Well, I've said this before, so sorry for the broken record alert, but really an opportunity to think about moving from things like standard of care to excellence in care. It's not a common scenario, but we're all going to see this patient. And if it's not PJP, it's going to be some sort of diffuse interstitial pattern, which is not necessarily a bacterial pneumonia. And good job for doing the Rocephin or ceftriaxone and the azithromycin. But if that's not the organism that you're looking at, maybe you've done a bunch of stuff that hasn't necessarily helped the patient. So understanding when to call for help when you need it, and understanding when things are deviating from normal. And we talked before, you guys talked about making sure that we don't anchor on things is super important to do. I hope that we have been true to the last hour of your life that you have shared with us. But most importantly, I hope this will be something that helps improve care of patients. I hope to see folks back next month. This is Monday, December 5th. 50-year-old man with a pneumothorax who had a chest tube placed, a little spoiler alert, and it did not improve the patient's pneumothorax. So there's some pretty good decision points. We'll announce our panel in the next couple of weeks. And again, thanks everyone. Have a good rest of your night. And thanks so much to your panelists for your expertise and your preparation for this. David, for you and Esther, writing an excellent chapter. See you all next time.